Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hello, everyone. Welcome back to the Breast Cancer Podcast. It is a very exciting day for me. Not only I have my wonderful partner and friend here with me, but I also have Dr. Kevin Hughes, who is a very respected breast surgical oncologist, not only nationally, but also internationally. He is director of cancer genetics, also McKoy Rose professor of surgery, and also at the Medical University of South Carolina in Charleston, medical director of Bermuda Cancer Genetics and Risk Assessment Clinic, also professor emeritus of Harvard Medical School. And he's recognized nationally and internationally. And I cannot tell you how grateful I am that you're here today. And we want to talk about high risk and use of artificial intelligence today. So, can you please, for the lay people that are listening to this podcast, can you please define what high risk is?
Sure. For me, high risk means either the patient is a high risk from a hereditary point of view, meaning they would need genetic testing and potentially additional screening for their family history, or they're high risk based on other factors like hormonal factors or pathologic factors. So, hormonal factors, as we all know, are early menarche, late menopause, late first birth or nulliparous. Uh, Pathologic are LCIS, carcinoma in situ, or atypical ductal hyperplasia, or atypical lobular hyperplasia. So we look at these different factors and they can be put together to develop a risk for the patient. And the idea is for a given woman who would normally start mammography at 40 and get yearly mammograms, does this woman need mammography or more intensive screening earlier? Does she need greater intervals? That's going to be based on her risk estimates. And the risk estimates, as I say, are based on those three sets of factors: hormonal, hereditary, and pathologic.
That's great. And looking at some of the other risk factors that would go into a woman's calculation, I know we have some different risk assessment calculators. Can you go into some of the other lifestyle as far as the obesity, alcohol, like some of those things that can be modifiable?
So there are modifiable risk factors, but they don't have the intensity of the other factors we're dealing with. So obesity, as you say, is a risk factor, especially in postmenopausal women. For all of us, it's a good idea to be at a good weight and eat properly, and that can at least decrease the breast cancer risk to some extent, but it's a relatively minimal extent. And I say that because I don't want people who are obese and get breast cancer then feel guilty for being obese, and I don't think that's fair. Alcohol use also, I think, I think Socrates said it a long time ago: moderation in everything. So alcohol use is not something I'm afraid of or tell people they can't do, but they have to be moderate. Drinking 5 drinks a night is probably not a good idea. Having a glass of wine with dinner is probably fine. So you have to kind of use some judgment in that, not cause people to have a lifestyle that they not affect their lifestyle as much as we might. I mean, having a glass of wine at dinner in Europe is just the norm. So
Yeah.
we don't want to impose on that.
Yeah. I think the other thing that we often forget is the radiation, so chest radiation. That's something we don't do as much anymore, but that could be another big risk factor that seems like we often forget about now for those people that maybe had lymphoma or the mantle radiation in the younger ages.
That's an excellent point, and I think we should keep an eye on, as we take our family history and personal history, we should pick up on the fact that a patient had a lymphoma at a relatively young age, and if that happens, did they have chest wall radiation, or sometimes for a mediastinal tumor, you can see this. The interesting thing with chest wall radiation is it seems to increase risk after the age of 10 and before the age of 30. And so from 10 to 30, it increases risk. Before 10, it doesn't seem to. After 30, it doesn't seem to. And I think that has to do with the maturation of the breast. The breast before age 10 is really not active. And if it's not active, it can't pick up mutations. On the other hand, after 30, the breast has really kind of hit its maturity. So it doesn't pick up more mutations from radiation at that point in time. So yes, chest wall radiation from age 10 to 30, definitely a major risk factor.
Yeah.
So, Dr. Hughes, you run a hereditary cancer clinic in South Carolina. I just want to kind of know, how do people find you? Like, how do they come into your clinic?
So the idea of a hereditary cancer clinic is relatively new, I think. We've found only about a half a dozen centers around the country that do this. We see any patient who has a mutation. Now, there have always been these specialty clinics. There have been adenomatous polyposis clinics going back to the 1950s, because that was all based on clinical diagnoses. There are Lee-Fermini clinics, there are Lynch syndrome clinics. But now, as we're testing more and more patients, genetic testing is now becoming just a commodity. Everybody's getting genetic testing who needs, well, not so true. We'd like to think everybody's getting it who needs it, but more and more are starting to get what they need. Now we're picking up more and more mutation carriers every month, and they have to be taken care of. And we're doing a panel that's anywhere from 25 to 142 different genes, and most providers don't know all those genes. In fact, I don't know all those genes.
Mhm.
So in this clinic, if a patient has a mutation, they're sent to us. We develop a plan for their management, and then we follow them. And we think that that's going to become the norm, because in the past, genetic testing was hiring genetic counselors and doing genetic testing. And how many people did you test? Today, it's going to be, how do you take care of the carriers? Because that's where the money is. That's where you make an impact on life. Finding a patient who's negative by genetic testing is good for that patient, but it doesn't change much. Finding a carrier and then manage them properly, that's critical.
Mhm.
And so how do they find us? A few ways. A lot of our patients, of course, are new as they're coming in, getting tested. We're doing in South Carolina the NRDNA South Carolina study with Helix Genetics. We do tier 1 CDC testing, which is BRCA, Lynch, and hypercholesterolemia on anybody over the age of 18 who signs a written informed consent, no counseling. So we're testing about 2,000 patients a month. That means we're picking up 10 or 15 carriers a month. So those patients are coming in. A major deficit of our management of carriers is cascade testing of relatives. So we make a real effort in this clinic that not only do we see the patient, but reinforce how important it is for their relatives to get tested. That brings another 1 or 2 or 3 patients per carrier in. And then every time we see them in follow-up, we remind them, how many of your relatives got tested? Well, you really got to get them tested. And kind of push that approach. So between our website, between some marketing, which we need to do more of, obviously, we get a fair number of patients coming in. And then we've also changed our approach. Initially, this was new for us. We made everybody show up in person. Now that we've gotten more comfortable with it, we're doing it by video. So that means we'll see a patient from 2 or 3 hours away in South Carolina and counsel them, but then their follow-up is done locally. And so we help organize that follow-up. We monitor the follow-up, but we're not directly doing the follow-up for those patients other than the monitoring side.
That's great. And what about those patients that are tested? Let's say they don't have a genetic mutation, but I know you've done a lot of great work with risk assessment models, and something that we are implementing or trying to implement into our EMR of taking that risk assessment on those patients. Are you guys doing that also electronically and calculating their risk? Typically, Tyrer-Cusack, or what other models are you using to identify high-risk women that are genetic negative for mutations?
Yeah, so when a patient is negative for a mutation, you definitely have to make sure that you follow them appropriately for other risk factors, as you've just said. So if they've had chest wall radiation, they're going to get MRIs repeatedly, as well as mammography. If they are a Tyrer-Cusack over 20% lifetime risk, which is a current approach, they get MRI in addition to mammography. So there are a lot of models out there: Gale, Tyrer-Cuzick, BRCA Pro, Babesia. I boiled it down really to two things I check. One is the NCCN guidelines. Are they eligible for testing? And second, Tyrer-Cuzick, are they eligible for MRI screening? I think those two models or approaches to risk assessment are really the two most important. Now, what's coming along is AI, as you mentioned. And with AI, there's now image-based risk, and we can talk about that at length. My own prediction is within 5 years, Tyrer-Cuzick is going to go away, and image-based risk will take over. But it's hard to predict the future.
And one of the things, looking at the high risk, also, I know for us, we have a challenge. When do we calculate that risk? Who's calculating the risk? All of the patients are hopefully being seen by OBGYN or primary care, family practice, and not seeing the surgeon unless there's an issue. So trying to figure out, when do we get those patients in for risk assessment calculation? Love to do it in the primary care office. Theoretically, would be great. Actual taking care of patients, I think, is a challenge. So we've tried to do it at the time of screening mammography. So a woman comes in for their screening mammogram, can calculate their risk. You said you're doing genetic testing on anyone at 18. Are you guys also having them fill out a risk assessment at the time that they're doing that genetic testing?
We are not for that, and that's part of population testing. You are cutting corners with population testing. There's no doubt about it. If we required full risk assessment, we required full counseling, instead of 2,000 a month, we might be testing 300 a month. Right. So you have to kind of pick your battles, I guess, to a certain extent. So for population testing, you're really stuck with the patient comes in, they get a test, you do whatever test you can do, and you're done. When should they get assessed? I think they all should get assessed by age 25. They should be assessed for the need for genetic testing. There's a tremendous amount of cancer risk between age 25 and 40 in these mutation carriers. If you don't know they're mutation carriers, they're going to come in with a large cancer instead of having had a test and been studied more carefully. So I think hereditary risk assessment should be about age 25, and then general risk assessment probably 35 to 40, because that's when the models really were calibrated for, and it's a reasonable thing to use that time frame to do that. But how do you get that hereditary risk calculated at age 25? We've been trying to do that for 25, 30 years.
That's the challenge, I know.
That's the challenge. So if you could build that into the EHR, and we've done that, there are companies that do that. And the genetic testing companies now have software that does that. But getting that implemented for everyone is a challenge, and I don't think many hospitals do it very well. What you described, doing it in mammography, is the approach that's most easiest. Okay? That's the easiest approach, because in mammography, forever they've been asking all the risk questions. They asked them all, they wrote them down on paper, they stuffed them in the envelope, and nobody ever did anything with it. Changing that over to now having electronic capture of that information and then running the models automatically, which is artificial intelligence. Now you can start picking up that risk earlier. But the mammography department has to collect the information electronically, has to run the risk models, has to look at the NCCN guidelines or run the guidelines, and then they have to act on it. And the acting on it is a whole other story.
So I was listening to a podcast talking about use of artificial intelligence in mammography, like in Sweden and Scotland. They, instead of having two radiologists looking at a mammography, they have an artificial intelligence and a person doing it. Do we have something like that in the United States?
I don't think that, that goes back to CAD, computer-aided detection in mammography. That's been around, again, for 20 years. The initial systems were relatively rudimentary, and they never really worked very well. They identified too many things, they missed cancers, so they really weren't accepted very well. Double reading with two humans reading it certainly picks up more things, but on the other hand, it's very expensive. We can't do that. So the idea of the second reader being an AI makes perfect sense. We just haven't got there yet. But we will, and that's going to be here. So there are two ways AI is used in mammography. One is what you described. So now a computer-assisted diagnosis on steroids, essentially. Those are being developed, but I don't think they're ready for prime time. And then secondly, our models like Mirai, MRI, MIRAI. Mirai was developed at MIT by Adam Yala and Regina Barzilay. They did machine learning. So getting into artificial intelligence, what machine learning is a different approach to building algorithms. So the normal approach we've had in the past is we identify what we want to do, we identify all the possibilities, we program into the computer all the possibilities, and then when the computer is presented a set of factors, it comes out with an answer based on everything we knew about.
Mm-hmm.
Machine learning is different. Machine learning is the machine makes the algorithm.
Hmm.
So what Regina and Adam did is they took a few 100,000 mammograms and they knew what the results were. This one showed a cancer. This one didn't show the cancer. This one showed a cancer 4 years later. They fed that to the machine and said, here are mammograms that showed cancer. Here are mammograms that didn't show cancer. You tell me what I should be looking for. And the machine then made an algorithm that said the next time a mammogram came in, was there a risk of cancer or not? And they predict risk of cancer over the next 3 to 5 years.
Hmm.
There's two possibilities with that. One is that they're looking at the mammogram and intuiting all the thyroacutic risk factors from the image and then predicting risk overall.
Hmm.
The second possibility is they're finding cancers we can't see.
Right.
And I think that's what they're really doing.
Yeah.
So I think where we're going with that, and I don't know if I got off your question, I apologize if I did, but the idea with this would be that when we do a mammogram, we run one of these models, and Mirai is a very early model, but these models are going to get better and better. We run that model. If it looks like that patient is at high risk of a cancer in the next 1, 2, 3 years, we do an MRI. And then we pick up that cancer with the MRI that you and I can't detect, and radiologists can't detect, by just looking at the images. That's what's going to replace thyroacutic. Instead of there's 20% risk over the next 40 years, it's there might be a cancer there right now. You better take a look. So that's my prediction.
That's great. And so that's looking at AI with imaging. I think another way to try to think about AI is looking at AI for the average person using their phone. So I tried to get on Chat GTP, one of the platforms, and have them calculate my risk and see if I'm at risk. I think eventually, if we get AI to look at our scales at home to see what our weight is and look at our grocery receipts to know how we're shopping and are we getting good produce or too many meat products, there's a whole way that we can use AI to calculate our risk. Is that something we can use for the people that, let's say they're in the mountains in Appalachia or someplace where they can't get to see the physician as much? Could we utilize AI that way to find out women that are at high risk and then make them, encourage them to come see the physician? Is there another way to utilize AI for the general population, do you think?
Oh, absolutely, absolutely. And again, it's how you think about AI. So when you think about AI as something new, because ChatGPT just came out. AI was first defined, well, not defined, described by Alan Turing in 1950. And Alan Turing wrote a paper about can computers think, and started to set out the questions of how do we get the computer, how do we know the computer is thinking? Then he came up with the Turing test, which was the idea that a human was talking to two other entities by teletype. And one entity was a human, the other entity was a computer.
Mm-hmm.
And when that person could no longer tell who was who,
Mm-hmm.
then they passed the Turing test. They were thinking.
Yeah.
As it turns out, ChatGPT passes the Turing test, but it's not thinking. So we have to reassess what the test is.
Mm-hmm.
So having said that, artificial intelligence is anytime the machine is doing something that we would normally do as humans. So risk calculators done by a computer are actually artificial intelligence.
Mm-hmm.
So we have, there are, again, I've developed this. There are companies that have developed this. The genetic testing companies have this software. If a patient puts in their information, and they do this now in mammography centers, then that information, those factors run through the models. Then the model comes out with, you need genetic testing, you need an MRI, you need earlier screening. That's artificial intelligence.
Mm-hmm.
The problem we've seen is that we can definitely get patients to put in their own risk factors and family history. We can definitely calculate risk. We can definitely say by the guidelines what each person should do. But we have not figured out a way to get people to actually do it.
to do it.
And that's a problem. It's a problem both at the system level and the patient level. So at the system level, does somebody tell the patient that they're at risk? And then how do they tell them? And how do they tell them what they're supposed to do? Is that a letter? Is that a personal phone call? Is that a conversation in the lobby? What is it? And then once you tell them they're at risk, what do? Do you test them right away? Well, that's very effective. Or do you say, go see a genetic counselor? Well, that you lose 30 to 70% of your patients when that happens because patients don't show up for the counseling. So we have to get the physicians to make the recommendations. We have to find out how to make them in a way to make the patient want to do it. And then we have to find a way to have it done in a way that's efficient and comfortable for the patient so it actually gets done.
Right.
Those are the parts we don't have very well yet. Now, having said that, let's look at artificial intelligence with Amazon. Okay, we all know what Amazon does. And you know that if you're looking at your laptop and it's snowing outside, you'll get an advertisement for snow boots.
Right.
Yeah.
So Amazon knows how to make you do things. We have not even begun to use that type of artificial intelligence in enticing people to do what's good for them. So I think that's another area that's wide open. How do well, if we believe in medicine, we know what's good for the patient.
Right.
So we think they should do it. So how do we make them want to do it? Or how do we make the physician want to take the next step? I think there's going to be a lot of personalization, social engineering, things of that type that we can't do as individuals, but we can do at an artificial intelligence level.
Dr. Hughes, you have alluded to in someone carrying a genetic mutation, 5 to 10% of the time they inherit it. The other times it happens sporadically, right, as in our lifetime. So I am a patient, I'm coming to you. Why should I get a genetic testing? How is that going to help me? How is that going to change like my life in a sense? Like, is it going to decrease mortality, morbidity? How is that going to help me to get genetic testing? This is for the lay people out there.
Oh, of course. So if you have a strong family history of cancer, and that's multiple relatives with cancer, young age of diagnosis, multiple cancers in a single individual, we use those factors to say who needs genetic testing. Now, I think we miss a lot of carriers doing that because a lot of people don't have a family history like that and are still carriers. But even that's the low-hanging fruit. If we can get those people tested, we can identify if a patient has a mutation and what mutation they have and what gene. Once we know that, we can modify their management to then decrease the morbidity and mortality of cancer. So as a perfect example, if a patient comes in and says there's a lot of colon cancer in my family, and I test that family or that patient, she has an MLH1 mutation, she's at high risk of colon cancer. Even if she's 25, she starts having yearly colonoscopies. Those colonoscopies find polyps and take them out. That actually prevents cancer. So that woman, instead of dying of cancer at 35, now gets a colonoscopy, has her polyps removed, and never gets cancer. Or we miss a polyp, they develop cancer, but we find that at stage 1. So these are interventions that we would never do in the normal population. None of us are going to have yearly colonoscopy. But once you have these mutations, you can get yearly colonoscopy. You can remove the ovaries. You can do MRI of the breast. You can do all these intensive interventions at a younger age to then help that person either prevent cancer or find it earlier. And that's the promise of genetic testing. That's what we really need to do. It's unfortunate. Right now, the majority of our genetic testing is done on cancer patients.
Yeah.
So a patient comes in, they have cancer, and then you say to them, oh, you're at high risk of cancer. You have this mutation. Well, that's too late. So we have to move it back, as was mentioned, we have to move it back to a younger age, get the risk assessment done early, and then identify that mutation, change the management, and then find those cancers earlier and more treatable.
Yeah, absolutely. We treat cancer, every day, all day. And my whole goal of this podcast is to educate and empower men and women so they can advocate for themselves. And I think this is a great example of that, how you can take that power back. In life, we really don't have control, but something like this, if I already know I have this specific mutation, I could be getting regular screening colonoscopies or earlier MRIs of the breast and mammography. The problem I have sometime in my own clinic is that I find people at their first screening mammography, they have cancer. And maybe that's the type of person, if they had genetic testing, and they may or may not have genetic mutation, but I think it would be better for those guys to start their screening earlier so we do catch cancer at early stage.
Absolutely. It's really a tragedy when a woman comes in with a large cancer and then you find out she's a carrier and you know you could have done something to prevent that. It's painful to watch. And unfortunately, we see it too often.
So let's say that you have that person that comes in, they've got, let's say, a mutation, and now you've seen their family member that's 25 years of age. Could you just go through, like, how do you counsel that person the first time meeting them? Because often people come in and say, okay, I don't want to get tested because I don't want to know I'm at risk. And I say, well, there's a few different things that we can do to help prevent risk. How do you counsel that 25-year-old that comes in that's scared, that does not have cancer, but that has a mutation?
So I think that goes into, how do you get people to get the medical care they need? And so we all, or the three of us here, absolutely believe that genetic testing is critical.
Right.
So we have to get the patient to understand that, and that is part of how to be a doctor. That's what we do. So with that 25-year-old, I identify their family history. They know they're at risk. They come in probably more scared than I could make them. They're already scared of their cancers. I explain to them why genetic testing can help them. Identify this mutation earlier, change their management, as we talked about. Explain that to them. Now, for young patients, what I do say, and this is important, is that there's no protection for life or disability insurance.
Mm-hmm.
So because of that, I try to get these patients to get their life and disability insurance in order before we do the testing.
Okay.
That's been our norm. Now, for health insurance, there's no issue. So we explain that there's no issues with health insurance, there's no issues with employment. The only issue is life and disability. And if they have that in order, it's not going to be taken away or raise their premiums retrospectively. So it's a matter of helping them to understand what their risk is and that we can do something to fix it. And I find most people very receptive to that. It's unfortunate that the vast majority of what we've done the last 30 years is tell people how risky genetic testing is. And I think we've hurt ourselves by doing that. In reality, this is a life-saving possibility. And so I want to make that clear to the patient.
And let's say they get tested and they have a mutation, then what do you tell that person? And I know the NCCN guidelines, but again, just talking to the general population who's out there, if they have a genetic mutation, how do you counsel that person?
So it's very specific to the gene and the patient. So what we look at is what's the age of the patient, what gene mutation do they have, what cancers have they had, and what procedures have they had. So if a patient's had a bilateral oophorectomy, they're no longer at risk of ovarian cancer. If they've had a bilateral mastectomy, they're no longer at risk of breast cancer. If they've already had ovarian cancer, well, we don't tell them they're at risk of ovarian cancer. They've already had it.
Mm-hmm.
So you have to kind of tailor it specifically to the individual patient. And then you tailor it to the gene. And for the genes, each gene has its own spectrum.
Mm-hmm.
So what cancers does that gene increase the risk of? So for CDH1, that causes gastric cancer and breast cancer. If you take BRCA2, that causes melanoma, pancreas, ovary, prostate, and breast cancer. So you treat those people differently. You concentrate on different organs based on the spectrum. The second thing is a penetrance. How often does that cancer occur? So you take an ATM mutation, that's 1 out of 5 will get cancer by age 85 in the breast.
Mm-hmm.
Okay, you might do more MRI. You do have more MRIs for that patient. You don't recommend prophylactic mastectomy. You take a P10 mutation, Calvin syndrome, they have an 80-90% risk of breast cancer by age 85. Now, prophylactic mastectomy might be a more reasonable approach. So you look at the spectrum, you look at the penetrance. Then you look at the age of onset. When does that risk begin? So for BRCA1, the risk of ovarian cancer begins age 35. Mm-hmm. So we take the ovaries out between 35 and 40. For BRCA2, that risk begins at age 40. So that woman gets 5 more years of normal ovarian function. Then you take PALB2, the risk goes up at 45. That's 10 more years of ovarian function. So you try not to intervene too early. You try to intervene when the risk begins to go up. So spectrum, penetrance, age of onset, that's what modifies how you manage individual patients on a genetic level. And then the personal level that we talked about earlier is what really fine-tunes that. So that's what we do in our hereditary cancer clinic. We look at all the factors, personal factors. We look at what gene it is. and we put a management package in place for that patient at that point in time with that clinical situation.
And I think that's important for patients to understand that it's going to be different. I think a lot of patients think they get genetic testing and we're going to really push for surgery. And that's something that I try to back up a little bit and say, okay, would you like to know? So don't put your head in the sand, kind of like the ostrich. And if they are 25, I've even had some patients come in and say, oh my gosh, I've got a BRCA. I'm supposed to get pregnant right now. And I'm trying to find a guy and I'm really nervous. I'm like, okay, let's settle down. Again, try to look at when would we do surgical intervention, but also just counsel the patient to do things like don't smoke, again, limit some of the alcohol use, exercise. So some of those things. And then from an imaging standpoint, I talk about the screening and the MRI and the mammography. For some patients that have, let's say, very fatty replaced breast on mammogram, and MRI is very costly, especially as we have the lower socioeconomic patients that come into our office. Are you ever skipping MRI, maybe doing every other year, every third year when they have an easy to read mammogram? Is that something that you push for annual MR for everyone? Let's say, again, BRCA2, BRCA1. How do you utilize the other imaging or exam findings, such as the fatty replaced breast on mammography?
That's a great point. You still pick up more cancers with MRI, even in a fatty replaced breast. So you're kind of stuck with the guidelines. So I do try to follow the guidelines. If the guidelines say yearly MRI, I'll tend to do yearly MRI. As a patient, let's say a 45-year-old woman, BRCA2 mutation carrier, BMI of 45, very fatty replaced breast, I'll still do the MRIs. But if I've got a 70-year-old woman who has very fatty replaced breast, now I think, backing off on the MRI makes sense. So you have to put in the other factors like age before you do that. But I certainly tell the patient what the guidelines are and then tell them why I'm modifying those guidelines.
Great.
So just for one example of that, BRCA2, males with BRCA2 are supposed to get mammography after the age of 50. I'm sorry, I don't agree with that. It doesn't make a lot of sense. So I tell the patient, look, you're age 50. This is what the guidelines are. I can go either way. If you're somebody who wants to do everything you possibly can do, let's get the mammogram. If you hate medical care, we'll just examine you once a year. And I'm comfortable with that, but I always get the patient as part of that decision.
That's great. And ultrasound or contrast enhanced mammography are utilizing other imaging techniques as well. Maybe instead of MR for some of those patients have fatty replaced breast, or you're not utilizing those other techniques?
We're not doing contrast enhanced mammography, but what I understand is that it's about as good as MRI. So if there's a cost, if it's better cost wise, I don't know the answer. If it's more tolerable for the patient has a pacemaker in, so can't get an MRI. Then doing contrast enhanced mammography is probably as good as MRI. On the other hand, ultrasound of the breast I don't think is as good as MRI. But again, if the patient can't afford the MRI, or she can't get coverage, or she can't get in the machine because she goes crazy in the claustrophobic issues, then do ultrasound. You do the best you can as a physician. I completely agree with that.
Yeah, great.
So you're running this hereditary cancer clinic in South Carolina, and if a hospital system wants to get into that type of thing, what are the benefits for the hospital system?
The hospital system. So, we are healthcare, but we're also commercial.
Yes.
Mutation carriers generate a tremendous amount of downstream revenue. So on the one hand, I know these patients need all these tests because it's going to make them have a earlier cancer or no cancer at all. So I know I'm doing what I need to do. For the hospital, I can say we're going to generate 10 MRIs for this patient in the next 10 years. We're going to find 3 more cancers if we do 100 of these patients. We're going to do more colonoscopies, more hysterectomies, more oophorectomies. There's tremendous downstream revenue. So I think the downstream revenue is the way that gets the administrators interested. The notoriety gets them interested because now you're doing something that other people aren't doing, at least for the time being. So that's what we use in our clinic, in our hospital. First we said this is a really good thing to do, and oh, by the way, we make money on it, and oh, by the way, it makes us famous. So that gets your administration happy. You gotta sell it to them for what they think is important.
Yeah, absolutely right. And women are primary care like drivers in the families, right? Like once women come to the doctor, then they bring their family members to go to the doctor. So I think it's good that women also know about these type of clinics and to advocate for themselves.
Yeah,
Absolutely.
that's great. $1 million question. Is AI going to replace us as physicians?
Well, the answer is yes. It's just a matter of when. No, I think the current saying, which sounds kind of trite when you first hear it, but is actually true. AI is not going to replace the physician. The doctor who uses AI is going to replace the doctor who doesn't.
Hmm.
And I think that's absolutely true. So for the next 5 to 10 years, it's going to be enhancement of humans, not replacement of humans.
Right.
And I would be very hesitant for my residents to not know AI, because that's going to help them determine how they manage their patients, what type of surgery they do, how they screen. It's just going to be what medications they give. It's going to be part of everything. We can't manage the amount of information we have today.
Right.
So with the amount of information that a doctor has to know, with the amount of factors a patient has to help determine what that is, we need AI. And we called it clinical decision support in the past. Our electronic health records do a lousy job of it. But there are good programs out there that do it now, and AI is just going to make it easy. The other thing is that there's huge amount of data in our electronic health records that's totally inaccessible. The only way you can get information out of the electronic health record is you take a fellow, you send him in front of the computer, and have him read, tomes of prose and try to sort out what are the factors in that prose. Well, now AI can do that.
Right.
So we're at the point now where we can start getting data out of that unstructured information in the medical record. That's going to improve medical care tremendously. But somebody has to understand how to do it, how to interpret it, what's true, what's false, what can you trust. So I think that's definitely coming. And then there's also the work saving side of it. We're developing a program now where if a PDF comes in from the outside and an outside patient, the AI summarizes that, so you don't have to read through 20 pages of PDFs to get out what's the summary for this individual patient. That's a major time saver.
Right.
So that type of thing is coming along where the doctors who use AI are going to be more efficient and more effective, and that's a good combination.
But AI cannot operate yet, right?
That's an interesting question. When you do a stereotactic biopsy, do you know where to put the needle? No, the computer tells you.
Right.
So to a certain extent, the computer is already operating. There is already AI determining how we do a procedure. Stereotactic brain surgery, you can't do it without a computer.
Yeah.
So, but again, right, for the moment, it's enhancement.
Right.
When it goes forward, it might be replacement, but it's going to be for simpler things initially. And I think surgeons are going to be maybe the last to go. I mean, when it comes to internal medicine, unfortunately, that's easier to computerize. How to deal with an operation, that's harder to computerize. And I think the last ones to go are going to be the trauma surgeons, because they don't know what the hell they're getting into when they open the belly. But eventually that's going to happen. But no, it's years and years away. But in the very short term, I mean, now computers have to be helping us to make better decisions. That's critical.
Yeah, that's wonderful.
Dr. Hughes, this has been such a wonderful conversation, and there's so much takeaways from this podcast for the lay people, for cancer survivors, for trainees who are residents and fellows, and for ourselves. And thank you for always advocating for all these nationally changing guidelines that are actually practice changing. And now you're part of the state of the art technology with using AI for women and men out there. And so we really appreciate you, and this has been wonderful, and you're doing this from the airport, and I cannot thank you enough for taking the time to doing that. So safe travels to you.
Well, thank you. And thank you for what you folks do. And this is amazing to get this information out to patients. This is a lot of your time. We're here on a Sunday morning at 7:00, and you're out at your studio doing this. I give you great credit for doing that. And thank you.
Thank you, sir.
Thank you.
Have safe travels.
Yeah.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
That was an amazing conversation, wasn't it, with Dr.
Great.
Kevin
Yeah.
Hughes? And what a phenomenal person. He's not only the director of cancer genetics, but he runs this hereditary high-risk clinic. He's part of this nationally practice-changing guidelines, and we talk about him at our tumor board conferences. He's so well recognized nationally and internationally. and he also teaches at Harvard. And so I just kind of want to know what your take was from this conversation.
Yeah, I think Dr. Hughes is tremendous. All of his previous studies that he's done, he's got a way of taking the risk assessment models and putting them together, and has something that you can put into your electronic medical record. And we've been trying to utilize that for years. So, I mean, we didn't speak enough of all the great things that he's done. And now looking at genetic testing of the entire population rather than just at cancer patients, I think again, this is going to be groundbreaking information once we get all of it. So truly an amazing position.
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.